Hi, welcome to my channel. Today I'm going to discuss what do we do if you have a patient with hypotension. So the driver of this video class is to guide you in or with your practice. Simple question as, why do we bolus our patient? So if your answer is to increase volume, then follow-up question, how? So if you know the answer, then good, keep it up, use it, and pass it on so that when you're precepting a nurse, they know. However, let me tell you what I think. Again, for those who are new to my channel, I am Manny and I am an ICU nurse educator. I have been a nurse for 30 years. Yes, 30 years. I have my MSN in nursing education and a doctor of health administration. So I have been an educator for 10 years now. So I did not start the job as being a nurse educator until I got 20 years of bedside experience. And even when I was teaching or doing a nursing education role, I still work at the bedside. It makes more sense and it's easier to teach if you have so much experience because you don't need a textbook to teach it. Pretty much you speak from the heart, from your experience, and also we call it as what Dr. Benner told us, that is that expert, subject matter expert. So I want you, and thank you for joining me and checking my website, because my goal is to share information to registered nurses, RNs out there. There were about 4 million RNs in the United States. And if you like this channel, come visit me again, because once in a while, if I have time, I'll post some educational video about nursing and what do you need to do. So as I mentioned a while ago, hypotension is the topic for today. Again, if you're a nursing student who's looking for information on how to manage hypotension, then good, you came to the right channel. But if you're an experienced nurse and you're just curious on what I'm gonna tell you, then finish the video and kind of review and reflect on what I just mentioned to add something that you did not know, or if you know anything or everything, then good for you. Use it because you are actually doing the good thing, the right thing. Collaborate with the MD, be assertive, and be a patient's advocate, right? That's what we do as nurses. We care for the patients and family. We help them to get better so that they can go home. So decreasing length of stay, decreasing ventilator days, and they get better, then good outcome. It's good for them. So I'm going to ask you again that question, why are we bolusing our patient? Okay, and what makes them low blood pressure? There's a lot of things, reason why their blood pressure dropping. So for one, I'm just gonna focus on management, because I know you probably took care of a hypotensive patient before. Either they're taking too much beta blockade, their metoprolol, their hydralazine. It's just their dosage is too high for them, or their volume deficit, or they're getting sepsis. So those are the things that I want to discuss. Okay, so I have a case study here. Mr. Smith was admitted in the ICU from ED, and he was brought in by the ambulance because of difficulty breathing, coughing for 5 days, weak, fatigue, and he desaturated in the ED on room air 88%. And then the doctors ordered 2 liters nasal cannula, oxygen, it went up to 94. Vital signs is 80/45, heart rate 125, respiratory rate 25, temperature 38.7. So this is your initial data, right, in the ED. However, until you get your labs and diagnostic tests, that's when you get to know more about Mr. Smith. But based off the current situation, this is your data in front of you. So the first thing you do is you look at your blood pressure. If you recognize that, good for you. You did it right. You're correct. Heart rate. If you think like 125 is a compensatory mechanism for low blood pressure, again, you're correct. RR 25, if you think like that's fast, you're correct. So there's so many indications why your patient is having rapid respiratory rate, right? One thing is the difficulty airway. So there's an airway issue, or it could be blowing up CO2, okay, because of metabolic acidosis, we don't know. Or the fever, 38.7. So now you look at this picture here, you're thinking sepsis, could be. So in the emergency room, if you're an ED nurse, you jump in right away and escalate issues wherein you will do your protocol, your sepsis protocol. It's meeting the criteria. Then what do? So you bolus the patient, right? If you don't have a central line yet, that's good. It's okay. Just put number 20 IV. Then start your saline. And then when you get your IV, you draw your labs there so that you don't have to poke your patient again. That's what the ED nurses do. They insert an IV, they draw blood, they put extension, they flush, they tape it, good to go, right? In the ICU, we are doing those kind of things also. It's just an extension of the emergency room. However, my question to you is, you need to understand what is your next intervention. So thinking ahead, okay? We always tell our nurses to think ahead. And of course, when you think ahead, you collaborate with the doctor assertively, okay? If you're a nurse if you're very assertive, good for you. But if you're that nurse who don't want to communicate, you're a little bit shy, get intimidated, then you need to practice some more. Okay, so if you get an order for fluids, that's good. I want you to understand the reason why we're giving them fluids. So crystalloid fluids are electrolyte solution that move freely from plasma to the interstitial fluid. Okay, so I want you to think about something that we do at the bedside. So you got an order to give 1 liter normal saline. All right, 1 liter normal saline. Some nurses would just give it. Okay, I agree. Give it because your patient needs it. However, if you're a preceptor and you have a student, then your student say, why are we giving fluids, normal saline? Then you might say increase volume, right? So you said increase volume. That's correct. However, don't settle there because I want to know how, right? So think about your plasma and think about your interstitial fluid. Okay, interstitial fluid. So there's a lot of nursing books that told us during our nursing school that it increased 25% of your plasma and it increases 75% of your interstitial fluid. So don't forget that. That's a very nice way of teaching our new grads, new nurses, or if you don't know, then now you know. Okay, it does increase. You're giving me fluids. You augment 25% of my plasma and 75% of fluids, interstitial fluids. So let's just say you gave me 285 ml and you gave me 285 ml in the interstitial. Then you're thinking, why it became 1100 ml? So that's the beauty of it. Because what you just did there is from the interstitial fluid, you have the intracellular and you have the extracellular, right? Within the cell and outside the cell. So 100 ml from the intracellular came out to the extracellular. And that adds into your, because it's saline, it's pulling water. So that is an easy explanation that I want you to understand why you're giving IV fluids to your patient. 1 liter gives you a total of 1100, 285 in the plasma level and 825 ml into the interstitial area. Okay, so crystalloids are organic salts and sodium. And the volume distribution I just mentioned here is that it uniformly distributed in extracellular fluid, your plasma and interstitial. Again, that 25%, and the 75%. Okay, so plasma volume is 25%, and it's infused will expand the plasma. And 75% infused will expand interstitial fluid. Okay, so therefore, 1 liter normal saline is to expand interstitial fluid volume, not the plasma volume. Okay, so use this analogy here. All right, so if you know the physiology behind this, then you understand what you're doing effectively with your patient. Okay, then isotonic saline. Somebody asked me, why do we call it normal saline when it is actually not normal? So it's true. It says there that normal saline is not normal chemically, so it should be called isotonic saline. So if you want to use that word, then go for it. Isotonic saline. However, what is it? Again, some nurses said, I don't understand what's the difference between saline and LR. Okay. Saline is a 0.9 sodium chloride. It has a sodium concentration of 154. It's higher versus 141 milliequivalent per liter. And it's also higher in chloride concentration, so 154 versus 103. It has a lower pH, 5.7 versus 7.4. Okay, so it's pretty much, we're giving it because you have the same, when we call your pH balance of your body, your blood. And it is actually makes more sense sometimes, but however, if you're giving it too much, watch out for hyperchloremic metabolic acidosis. So I think that's going to be on our next slide. So infusion of 1 liter, so this is 1 liter, sorry for the typo, of normal saline could add 275 or this is 275 ml of plasma. You're right, this is 275 here, and 825 ml of the interstitial fluid volume. So 275 and 825, yeah, it's 1100. So note that the total increase in intracellular volume is slightly greater than the infused. It is because there is a fluid shift from the intracellular to extracellular compartment. Okay, so this picture here is telling us you give me 1 liter of D5 water, it's just gonna give you an additional 100 ml into your plasma level, but 250 ml into the interstitial fluid. So it's not enough. So we don't use D5 water, and unless your sodium level is high, of course. Okay, so watch out your sodium level also before you're giving it your, before acknowledging the order with saline, because you need to know if they're having some hypernatremia, because it's not good. Okay, if they're having hypernatremia or hyponatremia. So again, here is your 275 in the plasma and 825 in the interstitial, and then your albumin, we all gave that albumin, and it gives you 700 into the plasma and only 300 in the interstitial. And if you have hypertonic 7.5%, it gives you 535 ml into the plasma and 700 ml into your interstitial. So I never gave that yet, unless if it's a neuro patient and they're having some sodium wasting symptoms, then you give them the hypertonic, neuro cases, or sometimes your SIADH, when they're having the retaining water and they're diluting their sodium, then it goes down, then you give them hypertonic or salt tabs, right? So go back to your hypotensive patient. Lactated Ringer, again, if the doctor said give him LR, especially if you're doing your 30 ml per kg, So the 30 ml per kg, guys, is what do we mean by that? So 30 ml per kg is if I weigh 50 kilograms, you're gonna give me 1,500 ml of fluids, right? So that's basically your sodium. So you give me 1.5 liters. So I want you to pay attention that you need to do your PLR first, passive leg raise. So what is passive leg raise? Passive leg raise is an independent nursing function. You don't need an order for that. What you're doing is you're keeping your patient head down. Okay, so flat. You do not put them on Trendelenburg anymore. I saw a nurse. She put her patient Trendelenburg, and I asked her why. She told me it's a doctor's order. Don't you not question doctor's order, guys? So that's just my question to you. You need to question the doctor's order, because we are now in that stage wherein we need to advocate for our patient. And when you advocate for your patient, you need to question if you think like the doctor's is not, or the doctor's order is not correct. Okay, so there's a lot of evidence-based practice out there and research that said Trendelenburg position is no longer true, or doesn't make any difference if you put your patient flat. Okay, in terms of telling us if the volume of fluids went back to the heart. Okay, because I think that's the point, is that they want us to return, increase venous return, increase cardiac input or blood from the blood into the right atria or right ventricle. But the question now is PLR or put them flat is just exactly the same. Let me tell you something. When I was orienting in this hospital, I was I volunteered to be pulled up or to be the model for lifting patient, how they reposition and everything like that with patient safety, mobility training. When they put me in Trendelenburg position, I think I almost passed out. I felt the blood is rushing into my brain, and probably my vagal nerve got really stimulated because of the pressure and blood flowing to my brain. And I almost passed out. I felt like I vasovagal. So I told them that, that was my experience. I don't know if you experienced it too, but please, 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 you do not put your patients on Trendelenburg position, even when you're trying to pull them up in the bed, to raise their head up. Just use your overhead lift. There's like lift machine or that most of the hospitals are now using. Okay. All right. So PLR is a passive leg raise. So when you do your S-bar, you call the doctor and say, hey doc, I have a patient who actually hypotensive right now, and background, what is the background? So tell them. And then of course you tell them, you mention about your passive leg raise, that it increases the blood pressure after, so that it's just an indication that your patient is fluid responsive. Okay. So PLR is what we do for assessing fluid responsiveness versus no fluid responsiveness. When you look at your Frank-Starling law, you increase the volume into the ventricle, you stretch that ventricle, and eventually it's just gonna contract stronger, right? So the more you stretch it, the more it's gonna contract stronger. But not all our patients are healthy or they have that. So if they're no longer fluid responsive, you did a PLR, nothing happens to their blood pressure, then of course you probably don't need volume. Okay. If you're in the hospital wherein you're using the Cheetah machine, then it tells you if your patient is fluid responsive or not. Okay. So that's just something that I want to share with you guys. So LR has I told you, potassium and calcium, and it's used as a buffer, and it metabolized or is metabolized to bicarbonate in the liver. However, I remembered that I will not use LR for my patients who are probably in shock states, like distributive shock or circulatory shock, because it says here, note that oxygen is required for this reaction. To become a buffer, you need to have a very good oxygen level. And if you have a very hypoxic patient, it won't, lactic acid or the LR will not act on as a buffer source when the tissue is hypoxic. Okay, so just FYI. So what is the implication? If your patient is having like circulatory shock, and if you think like they're ordering LR for fluid replacement, question that. You're probably better off giving saline, normal saline, or isotonic saline. All right. And in addition, the lactate requires a reduction in chloride concentration for electrical neutrality. So your chloride concentration in LR is close to that in plasma, which minimizes the risk of hyperchloremic metabolic acidosis. I told you guys, like, if you're giving your patient too much saline, isotonic saline, you end up giving them hyperchloremic metabolic acidosis. But that's just a very rare case. It's not gonna happen all the time unless you gave this patient too much normal saline. Okay, so again, guys, pretty much that's the end of the presentation. I just want to make sure that you're clear with this, that your role is, especially on a septic patient that you think your blood pressure is going down. Now you know why you're giving normal saline. So again, it raises your interstitial fluid and not the plasma, although the plasma will still gonna go up 25%, but 75% are in your interstitial fluid, and it is pulling 100 ml from intracellular out to the extracellular to augment your patient's blood pressure. All right, I'm hoping that this is helping you to improve your nursing role, your job, your workflow, and please pass it on to your new nurses that you're precepting. If you have a new nurse and they don't understand why we're giving it, it's just answering why and how. Why are we giving normal saline and or boluses, and how it really affect your body. Thank you.